regarding knee arthritis, which is always a big topic, especially in the primary care world, primary care sports medicine world, and the physical therapy world. As soon as Kevin gets out of there. Awesome. A couple things going through here. We've had this talk a couple times, so we try to make it as up to date as possible for you, and get on the maybe on the cutting edge things that are going around there, but it still is a very big industry, or a very big money maker, or a very big money depleter, depending on how you look at it. Knee OA is. So knee OA is a knee osteoarthritis. Throughout the course of the talk, it will be represented as OA or KOA. And while you're going through here, and of course the answers will be at the end, but these are the things that certainly can think about while we're going through the talk. Is a lot of our patients will ask or will tell you that things may or may not be related to osteoarthritis, such as wearing high heels. Of course, everyone will tell you that, oh my God, my knee hurts, I can't exercise, I can't do anything until I get my knee not hurting anymore. It is, could be a serious health problem, yes, no, or depends. There is certainly a large amount of weight going through each knee joint as we step, and so losing some weight might be very effective. Is knee OA a normal consequence of aging, and is surgery always required for knee osteoarthritis? All right, big numbers. Very large number of people in the country do suffer from knee osteoarthritis, making it a very big industry and also a very big moneymaker. And also a money depleter in the workforce. A lot of people ask for permanent disability or even short-term disability associated with the knee osteoarthritis, and that also is a very common question in my clinic as well. One of the reasons why it is a very big health concern is actually an indirect correlation between osteoarthritis and actual cardiovascular disease and death because of the lack of walking, because as we know, walking is likely one of the best exercises we can do to preserve our heart function. So if we can get people walking, we might be able to prevent some unnecessary deaths. Historically and currently, the standard of care for osteoarthritis is to target inflammation and inflammation alone, meaning the synovial lining, maybe the joint itself, and to relieve pain, because quite frankly, pain is really the only thing the patient is focused on in the knee osteoarthritic setting. However, if we were able to jump over to Kevin and change the actual milieu or the environment associated in the joint itself, and changing the biochemical environment, we may actually be able to impact the disease progression itself. However, right now, although orthobiologics are a hot topic, at least in my clinic, a lot of people can't afford it, and it's still completely out of pocket. All right, so what are the risk factors? Many of them are non-modifiable, but we're going to focus for the next few slides on the main modifiable one, which is the obesity epidemic and increased weight in our population. Since 1975, there's been a triple in the prevalence of obesity in this country, leading up to almost 40% of the population suffering from obesity. That is defined as greater than 30 BMI, which is still not as robust marker for measuring obesity. However, we still use it. If we were to have patients out there ask how we go about losing weight, or how we go about what is our target weight, our target hopefully BMI is below 40, but best case scenario is less than 30. Obesity itself not only changes the biomechanics, not only mechanical stress, but also has a systemic inflammatory response in the body that could be leading to further destruction in the knee joint itself. This increase in osteoarthritis of the knee has led to many surgeons enjoying the outcomes associated with the multitude of knee replacements in the country, which will continue to increase as we continue to still not modulate the biochemical markers associated with arthritis. All right, nearly 40% of us in the United States are considered obese, and associated with that, many millions a year die. So how do we go about combating it? Diet and exercise. Doc, my knee hurts, I cannot exercise. If I exercise, that's the only way I'm gonna lose weight. What I like to try to tell patients is that, listen, you diet to lose weight, you exercise to get fit, but you can obviously do a combination of the two to be the most robust. But there are very few randomized trials out there to compare individually diet, individually exercise, and with both. It seems that most people have more of an adherence to a diet as opposed to an exercise program, which all you physical therapists out there, that's who we rely on to then start developing some good habits in terms of an exercise program. Many diets out there, including ketogenic, all the new fads, most studies are still not supportive of any one kind. And of course, fad diets are just that, fad diets. So Mediterranean diet, high in olive oil, the omega-3s, and low in saturated fats seem to still be effective in cardiovascular and also weight loss. All right, so how do we make the diagnosis? This is diagnosis. We don't really need anything other than the history and physical examination. So this might be a little redundant to the primary care docs out there, but it's worth saying because I think a lot of times the patient will go to a physician, have knee pain, and expect an MRI immediately because that's what happens on ESPN, and they will then get a scope, and then they will be back maybe tackling somebody the next day. That's not necessarily the case. So remember, in somebody over the age of 45 who has knee pain that is not associated with a traumatic event, progressive in nature, plus or minus an effusion or swelling, worse when they first get up in the morning, half an hour later they get a lot better, and then after they exercise it's worse again, likely you have a slam dunk diagnosis of knee osteoarthritis. Don't really need to go further than that other than start treating. However, come to our clinic, get your x-ray. There's one of the good confirmations up there associated with all the different things that we see on an x-ray, the decreased space, this particular is the varus compartment, and then an actual changing of the bone, and then we'll classify these and then determine what the actual next step is for treatment. So once again, MRI is just such a, I think, in my opinion, an overused diagnostic modality in knee osteoarthritis, especially in someone over the age of 45. They come in, once again, you diagnose them in your clinic, and they haven't been treated yet. They don't have an anti-inflammatory on board. They haven't gone to any exercise program because what will likely happen, that MRI of that particular knee up there is going to show a terrible medial meniscus, if at all, and it will be a complex tear in the medial meniscus. The patient reads that report, and then they want surgery. Well, we also know now that surgery is likely not going to be more effective in terms of an arthroscopic procedure than the actual conservative treatment itself. Once again, signs and symptoms that the patient will complain about. Listen to your patient. I know we all, especially at FOI, we are going through a new EMR change, so you don't just sit there at the computer typing away. Look at your patient, talk to them, get some key things in the history and glean out from them what it is that their goals are and what it is that they are actually complaining of. What is also interesting is that oftentimes we'll get an x-ray of a knee, and weight bearing is very important. We'll get a bilateral weight bearing. They'll complain of left knee pain, and actually the right knee looks worse than the left. So the predictability of osteoarthritis is the unpredictability of it. So once again, that's why x-rays are not slam dunk. It is the history and the physical examination. Messy slide, big old star. I drew it myself. And the big thing here is to make sure that we reiterate to our patients that of all stages of osteoarthritis of the knee, the main component is a regular exercise program. And a regular exercise program we'll get to in just a second, not only keeping the joint moving because motion is lotion, but also we can affect the stability of the knee joint itself. As the cartilage leaves us, the instability goes with it, or the stability goes with it, but we can absolutely modulate the tendons and muscles around the knee that we can then support it a little better. Moving, get moving. It's just, Every single day I have this conversation, and it's always the same. Once again, you have to kind of break this prejudice that patients have that if they have no pain, they'll be able to move and they will be able to lose weight. But we need to break the prejudice that you have to get out there and start moving again. You don't just sit there and say, I'm going to have pain just because when I first get up, it has pain. 180 minutes a week, that's what we are suggesting to patients to move. Get in the pool, get on a bike. You don't have to run. I know a lot of people out there, I only run. Just get moving. Get that joint moving because motion is lotion. Most cost-effective in the treatment of osteoarthritis is a supervised exercise program focused on the hip abductors for the physical therapists, so thank you very much out there. And also the quadriceps and hamstrings, all the musculature that crosses the joint space itself. So that is the first thing that we need to direct people to, get them reduce their pain a little bit and then get them moving and then strengthen the muscles around the knee so that we can support that kneecap, the knee better. Then the other side of it is that people 6 months later will come back and say, I'm in pain. Well, did you go to physical therapy last year? Yeah, it didn't work. So you went for how long? 6 weeks. Awesome, awesome. How were you after physical therapy? Out of pain, completely out of pain. And what have you been doing since then? Cheetos. I don't have a gym. I'm not going to go out and walk. It's because they don't have the motivation. So it's almost our job to try to motivate them, get them with a group's silver sneakers, something that will motivate them to get back out there, because if they continue the home exercise program, they're going to be very well benefited. Another thing to say, certainly, about diet too, I think we as healthcare providers do a very poor job of having somebody come to the clinic. You have knee arthritis, we haven't treated you that yet, your BMI is 35.6, and we tell you you're fat. All right, well, I just pissed somebody off, you're fat. Well, what are you going to do about it? Here, I want to give you the tools. There's a couple medical weight loss programs out there that I've been connected with. Shake It Off is one that I've been using to really help people get their tools to eat appropriately, better for their own selves, and instead of us just telling you, you're fat, get out of my clinic. So of course, in our medicine, pharmacologic step-up starts, as we all know, Tylenol, NSAIDs, and then the COX-2s, depending on their tolerance. But as you also know, that anything given orally will always have some sort of side effect that you need to watch out for. NSAIDs, of course, gastric and cardiovascular. There are some studies that may support diclofenac at 150 milligrams a day is superior than the other NSAIDs, but in my opinion, ibuprofen, the tried and true old drug, is also very good. I don't mind using it for 10 to 14 days scheduled, and then after that as needed. And I won't discuss opioids for this one. Once again, diet. Diet is always so controversial. It's so hard to study because we are, many different things are going in our bodies. Everybody is a little different. We metabolize things differently. I do have a slide for those questions out there from a previous talks about turmeric, some few studies by the Arthritis Foundation, and the supplements that may be supportive in an anti-inflammatory overall diet, but that's what diet and the supplements are presumed to attack or presumed to decrease, is the inflammation, overall inflammation in the body. Glucosamine is once again inconclusive, like Scotty said, and the other ones up there just taste good. Glass of wine, probably. Topicals, we also do topicals. I like to try to get the people away from orals after they've gone through a flare-up of arthritis itself. Topicals can be an adjunct and or a bridge to either nothing at all or helpful, but it's still, some people will get some benefits, some people will not. So it's just kind of dependent upon them. NSAIDs such as Pennsaid and Voltaren, and then local compounding creams, which can be very expensive, so you must be very careful what you compound it with. So just an anti-inflammatory and an anesthetic such as lidocaine is usually covered by insurance. Capsaicin is hot peppers. I don't like rubbing habaneros on my knees, but if you do, they might have a local inflammatory response that people will use. All right, what about injectables? We'll just briefly go through these really quickly, but we, of course, start off with corticosteroids as a standard of care. A new one out there is an extended relief of triamcinolone, which does show to be more effective at decreasing the side effects as regular triamcinolone. In other words, the loss of cartilage and very similar benefits at about 24 weeks in patients. Viscosupplementation is still inconclusive, although we use it. I'm very careful of people who do have pain at rest, at sleeping, at all times. I tend to tell them I think we need to talk about something else. All right, biologics we'll skip, and here is the slide that I do give this list to my patients itself, and the amounts that may or may not be beneficial. Glucosamine and chondroitin, we do hang our hats on the GATE study, and they do need to be taken in conjunction, not just separately, and they are compared to an NSAID and Celebrex in that particular study, but still not very good science. Boswellia is a pine tree bark extract used in Europe, and it causes diarrhea, which is always fun. Curcumin, 2,000 milligrams a day is suggested. And then, of course, the CBD oil. I've talked to a lot of different people. There's so many things out there, and certainly I just want to line them all up and take them all in one day to see what's most effective for me. But I did talk with a local pharmacist at Davis Island Pharmacy, and he's done a really good job of kind of researching everything for us. And he suggested a brand called Avanda. I am not on board in anything associated with Avanda, but he has done his due diligence, and that's what he sells at his pharmacy for CBD oil. People at the gym love it, either both sublingual, rubbed on, or both. All right, of all the things we throw at you, get moving. Get rid of the prejudice, give them tools to lose weight. That is the only modifiable risk factor associated with knee osteoarthritis. Still a big business, and if we can just get Kevin's stuff to work, we'll be good. Just kidding. All right, that's my talk.